Okay.
Right, it's 5:30. Larry, do we want to go ahead and get started?
Yeah, I'll just let people in as they come.
Who
Yeah.
else are we expecting? I see we've got all the board members. We're
Invited all of,
expecting Dr. Pavia, be a little bit late. And
I expect the rest of cabinet. I invited Brian, Becky, and Chris.
okay, well, let's go ahead and get started then, and
We're
they can
live.
join us. All right. I'd like to welcome everybody to this study session of the Salt Lake City School District Board of Education. It's October 27th, 2020 at 5:30 p.m. This is a study session of the board. We're here, the board members are here to learn. We'd like to welcome Dr. Hirsch and thank him for attending this study session, as well as our meeting last week. Those of you who are watching and board members know we had a lot of questions. And so this is a good opportunity for us to learn more and to ask those questions. I know due to busy schedules, Dr. Hirsch and his colleague, Dr. Pavia, who will be joining us a little bit later, need to leave by 7 p.m. So we will be ending this session at 7. We're going to start with Superintendent Madden going through about 8 slides to seed the conversation. And then we'll have some questions and answers, which we'd like to do round robin style. So we'll start with, how about we start with our student board member, Dottie Uman, and we'll go from precinct 1 through 7, which each ask a question. And we'll go through as many rounds as we can, Dr. Hirsch, until it's time for you to leave. Does that sound fair?
Yeah, and I'm happy to stay as long as necessary. I just didn't know what the anticipated timeline was.
Okay.
We'll target 7, but if we need to go longer, we'll
how
do it.
about that? How about that? We'll aim for 7.
Yeah, this is kind of an important issue.
Well, thank you. It is certainly is for us. So and you. So thank you. So that'll be our aim, 7. But if we've got pending questions, board members, Dr. Hirsch is gracious enough to stay, and we can make sure we get those questions answered. So I will turn the time then to you, Superintendent Madden, to go through the slides.
Yeah, I've just got a few slides here just to kind of seed the conversation, and Dr. Hirsch has seen these slides. So let me just jump to that. And again, if Dr. Hirsch, if you want to input anything along the way, certainly feel free. Just wanted to update on the positive test percentages. So in Salt Lake County, the top positive test percentage right now is at 18.98. That's averaged over the last 7 days from October 18th to October 25th. In Salt Lake City School District, it's averaging about 17, ranged everywhere from about 9 to about 23 as you move around the district, but an average of 17. This is a breakdown, an update. You've seen this table before, but it's updated from the Salt Lake County Department of Health, and this is age group data broken out. There's been just a slight rise in the percent of cases that are falling in the 0 to 9 range. But aside from that, these numbers, at least in the lower range here, are fairly close to what they were the last time we saw this. I believe that the number for 0 to 9 was 4% then, and I think the 10 to 19 was about 17%. Some of those 10 to 19s are probably moving up into the higher ranges now. The next slide, Adam and I talked a little bit about this one. This one's all of these I think need to be taken a little bit with a grain of salt, and maybe can use a little more information. But this one in particular is just a raw count of cases. This is off the Salt Lake County Department of Health. This is all districts' total cases, cases in the last 14 days, and that's how it is on the charts that break out by district. Is the dark blue is the cases in the last 14 days, and the light blue is cases older than 14 days. For Salt Lake City, it doesn't. We've had 34 schools that have had some level of impact, a total of 85 cases, and 32 cases in the last 14 days. But those were too small to show up on here. when you go to the website itself, you can select by district and look at the individuals. But, just to note, I mean, Canyons is 1.5 times as big as we are. Granite's 3 times as big as our district. Jordan's 2.5 times the size of our district. Murray's probably about 1/3 the size of our district. So just to put it in perspective, those would matter in kind of looking at these numbers. This is a slide that we have shown one time before, but just a reminder about the younger grades that we were looking at. And there was this study in Utah released in September 11th. That's a little while ago now. Indicates young children infected at daycare can spread coronavirus at home, but that coronavirus is less severe in children than it is in adults. They can still play a role in transmission. Lower number of cases for 0 to 9. We looked at that on one of the graphs earlier. And 0 to 9 appear to have a lower probability of contracting COVID-19. And then I just want to show you, this is just a set of slides that Dr. Hirsch and I saw in another presentation that we were both at. I just thought it was kind of interesting. There was just it's a comparison. So there was a camp in Georgia. I think a lot of people heard about this. This was back in June. This is kind of just the numbers for that camp. But essentially, they had 360 campers, ages 16 to 19, indoors, outdoors, singing in cabins, no masks for teenage, no masks for the kids. And in teenage staff member had symptoms that showed up on June 23rd. Okay, and so I think these things are important, like limited cloth mask compliance. They did have a test before arriving, but it was within 12 days before. And the results of that were that they had out of 597 total people, they had 260 cases, which was a percent positive of 44%. Seemed to be evenly split on males. This particular instance saw a little higher incident in the 6 to 10-year-olds, but pretty high across the board. And I thought what was interesting was just contrasting that with another camp. And this was some overnight camps in Maine. And the difference was they did tests at the start. They were meticulous with masks. They cohorted students, monitored distancing. And what they saw was, these are the results here, was no additional infections were known to have occurred. So following the safety protocols led them to a very, very good result in a very similar situation to the one that they were in at the Georgia camps. And so the key takeaways were masks were very, very important. And I think we hear that every conversation that we're in now. Kids should wear masks and can wear masks. I think that's been shown as well. And then compliance needs to be very, very high. Most transmission occurred from staff to campers, but children can transmit, and that distancing helps as well. So that's just a very, very little bit of information, but I think at that point we can turn it over to questions.
Dr. Hersh, do you have any comments you'd like to make before we open for questions?
Yeah. I wish we had more, what is the date? It's the end of October. We here locally, statewide, and nationally, people are rapidly trying to acquire data to better inform, our practices. I think Superintendent Madden was showing, data from camps just because that's kind of that's largely the experience that's been reported and publicized in some daycare experiences. And I think the main conclusions, just reiterating, are, children will get infected, can get infected, and can transmit this virus. So some of these considerations around, well, do they get infected less often? Do they those are epidemiologically kind of interesting considerations, but more importantly is, they get it, they can transmit it, but at the same time, it can be prevented with the use of rigorous adherence to mitigation practices. I think that's kind of the summary of sort of what we've learned so far from congregate settings, daycares, and camps. And we're rapidly acquiring data, not just locally, but nationwide around the experience in schools. And we can talk about some of that, as we go. But let's
Thank you.
take some questions.
Okay, let's start with you, Dottie.
Okay, well, thank you for being here. So I know right now we don't have access to the rapid antigen test, and even if we did, they're priced pretty high right now, aren't they? Like, I think if you buy them in bulk, their price goes down, I think, to a max of like maybe $5 a piece. Do you think there are any tests that are on the horizon now that could be cheaper?
Not that I know of that are on the horizon for kind of this school year I'm aware of.
Mm-hmm.
I know that there's a lot of interest in what's called lateral flow assays that could be administered at home very, very inexpensively, adapting from some of the technology that's been used in resource limited countries, for instance, for malaria testing. So the technology is there. And I think that there are a number of investigators and small startup companies that are working on this challenge, but I'm not aware of anything that's kind of in the foreseeable future for us kind of this winter, spring, but I guess stay tuned. And that's sort of our job to be on the lookout for these things, because, you know, even tests that are, you know, not suitable for clinical practice, like you go to see a clinician and you're sick, you need the best quality tests in that context. But what we're talking about and what we have a need for right now is screening, mass screening for a respiratory virus. And it doesn't have to be perfect. It just has to be better than not screening to make a dent. And so we'll keep our eyes on that, because that could be very valuable.
Okay, thank you.
Michelle, do you have a question?
Yeah, so Dr. Hirsch, the younger grades show with the masks and social distancing that they are at lower risk. But I guess my question is, have there been studies on students taking it home? Because obviously in the classroom, students don't teach themselves. They don't live by themselves. There are other people, you know, in the household and in the school. So, you know, how do we trace that? I mean, is there contact tracing going on in those terms, or?
There is, and it's a great question, Michelle. You know, we know from actually the highly publicized daycare study that was in CDC's journal, the MMWR, it's worth a peek. We know that, again, this is early, you know, these are daycare children, they're not using masks. My son just walked in with a mask on. That's a good sign. Good job. But we know that, you know, children can acquire this virus in a congregate setting and can bring it home to their family. I mean, that's just basic virology, and there's no reason not to think that couldn't occur. The question is, can they get it from school, and how easily would they get it from attending school? The early returns on that are that, you know, from talking to a variety of districts throughout our state and the directors of the health departments, people are not finding evidence in their contact tracing that transmission is occurring within the school building. The absence of proof of that is not evidence of its absence, but we are not seeing the accumulation of stories, anecdotes, and clusters that seem to be linked to attending school. But should a child acquire the infection in school, you better believe it, they could bring it home to their family and to their other, you know, acquaintances, friends, etc. The issue is just, is that the place where they're apt to get it? And, you know, the emerging consensus is that, you know, school is not the origin of transmission. And rather, actually, it's more the concern that children, youth, staff, teachers acquire the infection in other parts of their life, but then potentially bring it to the school environment. And then, you know, the hope is that all of the mitigation strategies, universal masking, distancing to the extent possible, hand washing, et cetera, symptom screening, staying home with, the whole thing. I mean, that puts the transmission risk in that environment, potentially as low as any environment. I mean, we've learned a lot also from the healthcare environment, where that when in the actual practice and delivery of healthcare, transmission rates are extremely low. But there are breakdown points. For instance, break rooms have been shown to be a common place where transmission may occur. For instance, in the healthcare setting, the same could apply in a school setting. Lunch is a huge challenge, because it requires taking the mask off. Faculty lounges, et cetera, where people may want to have a break from wearing a mask and are eating, et cetera. Those are points of vulnerability. But by and large, the emerging body of evidence over the last 6-7 months, congregate settings where masking is, high compliance with masking, that transmission in that context is really low. But to your original question, Michelle, absolutely. I mean, it doesn't matter where you get it from. If you get it, you're gonna spread it to your close contacts, potentially. We know that the household transmission rate in Utah, and probably is generalizable to other areas of the country, is somewhere in that 10 to 15% range, but that's household transmission. That's not functioning the way people function in a school environment, because it's your home and most people aren't using masks and aren't necessarily minding their distance in the home environment. But that represents sort of a high mark, and obviously the goal is to transform the school environment into an environment that puts that transmission risk as low as possible. But we don't have really good studies yet that have reported publicly on school clusters and the origin of those infections and the secondary transmission. But that's coming.
Go ahead, Mike.
Doctor, how confident are you that with proper protocol, we can keep these children safe in schools?
Well, so I guess the answer to that question is sort of depends on how we define confident and depends on how we define safe. I believe that we can keep, at least in my view, we can keep schools safe. I believe that schools, the way they're being conducted now, are among the safest environments that a lot of youth are participating in. And I think that one of the things that we didn't know when school began, but I think we've learned quickly, is that by and large, all the members of the school community are really committed to the mitigation strategies, and these mitigation strategies are extremely effective. And I think most importantly, I think where there was some uncertainty was for the younger children. I mean, the extremes are always where the challenge is. The oldest kids in high school, want to push back on the rules. The youngest kids, they don't necessarily understand the why. This is an anecdote, but the accumulation of anecdotes, the younger children probably are outperforming all children, any other age group in terms of their ability to, go along with the crowd, wear their masks, etc. I mean, you hear stories of kids going to, elementary age kids going to play dates and insisting on keeping their mask on, going to playgrounds with no one there, literally empty playground, but insisting on wearing their masks. And, what we are starting to really believe is that actually the attendance at school is teaching kids how to function during this pandemic. I mean, if we could live our lives outside of school the way the kids are living their lives in school, we would move the needle on this pandemic in a big way, because what they're doing in schools is what we all need to be doing in most other areas of our life. So I feel like, there's always going to be exceptions. There are clusters around. I mean, it's not to say that there aren't cases that are emerging and are extremely disruptive, especially at the high school level. This has been very disruptive, we know, statewide. But what What is but it's been a different story in elementary schools. And we can talk about some of the differences there. But despite the disruptions and despite the large number of cases that in some cases are occurring associated with high schools, there's not been evidence yet that the acquisition of the infection is happening in the school environment. It may be, often it seems to be associated with school-related activities where masking compliance may not be so good, or just the inevitable socializing that happens, especially among high schoolers after school.
Okay, thank you very much.
So, Dr. Hirsch, you may have answered my question with the end of your answer to Mr. Namilka. But my question is, how would you explain the graphing that we see in the Salt Lake County, where the numbers in Salt Lake County go up starting in September? And obviously we see the later graphs show that they're school clusters. And so you would talk about that with school activities is what you'd say. And you'd say also that we don't have enough evidence.
So
I guess I've got a couple extra questions for that. And I do understand that mask compliance is really high. I have seen the studies, especially in other states, for younger children. I mean, I understand that I've seen those studies that mask compliance for young children is really high and really good. So I guess I would ask a couple things, and that is that I do know that if you're talking even with N95s, that sometimes virus do even infiltrate N95 masks. And certainly when we're talking about cloth masks or masks that aren't quite the same quality, we're not giving our kids N95s. I know someone well who wore masks always outside of the home and did catch COVID. Was probably caught COVID on a hike when the person was wearing a mask, and but was hiking around people that were not wearing masks. So I'm wondering what you think about that, the problems with that, and teachers' risks with that kind of things. Older people's risks with that. And then I guess those would be some of my questions about that, and what kinds of risks are we looking at? I guess that's my first set of questions.
Yeah, no, those are great questions. We'll try to go through them as best I can and kind of give you my input, my opinion, and I wish we had better evidence to answer some of the questions that you're raising. So the first question is, or the first observation is that there is a rise in cases among all ages, initially among adolescent ages, and then lagging behind middle school ages, and then subsequently elementary school ages. That does coincide with the start of the school year. I mean, that's just, we can look at the state data, show that in our state. Now, whether or not the really important question is that sort of a coincidence? And when you look back at it, you actually can see that the rise was beginning among adolescents and young adults actually before the opening of school. So we were kind of already going on this upward trajectory in the latter part of the summer. And the writing was kind of on the wall there as people were mixing more and more casual social gatherings were occurring. And we know that this infection does not contain itself to one kind of age demographic. Once one age group gets it, such as like the young adult group, we know inevitably there will be secondary transmission to different age groups. The question that is so critical to this conversation is it a coincidence that there appears to be a continued rise after the opening of schools? Is it related to school operations, or is it related to just what people are doing in their lives outside of the school environment, some of which may have been inspired and triggered by reattending school? I mean, I think what we talk about a lot is the cascade of activities, especially among the high school kids. When the high school kids began to come back to high school, beginning extracurricular activities, seeing their friends more and more, there's inevitably going to be more opportunities for socialization outside of school, and many of those opportunities, don't involve masks. So there's kind of distinguishing between what happens in the school environment and what the reinitiation of seeing all your friends and your peers may do in terms of triggering a set of other social activities that may not have happened had school not open, but are occurring separately from school. And we just don't have the answer to that, but in the accumulation of evidence throughout the state around the clusters that are occurring, particularly in high schools, seems to link these back to casual social gatherings that are happening away from school, extracurricular activities, which sometimes require or are a challenge to, have high mask compliance, such as certain types of contact sports. And so it's school-related activities, but not necessarily within the school building itself. At least that's kind of the emerging consensus. One of the things that Superintendent Madden and I and some colleagues at the state and county health department have begun to try to look at our data that we have at the school district level, at various school district levels and at the state level about the incidence of cases based on where individuals reside, and asking the question, is there a difference in the incidence of infection among school-age children who would attend school in the Salt Lake City district, but who are attending school remotely only right now, as compared to their peers in neighboring districts who in most cases are attending school in person. And it gets difficult in epidemiology to compare neighborhoods and zip codes, et cetera, but these are all neighboring districts, and we are in the process of trying to examine this question. This kind of investigation has taken place in some other metropolitan areas in the United States, and the emerging consensus has been those districts that are not attending school in person but are attending remotely are not experiencing higher rates among school-age children than their neighbors who are attending school in person. That remains to be seen if that's the case here in our region. We'll have to, we'll certainly let everyone know kind of what we learned from that. I think that's really important information for us to learn. Again, just kind of repeating, how are kids who reside in Salt Lake City School District, who attend school remotely right now, how are they faring compared to their peers in neighboring school districts in terms of the incidence of infection? And we need to look at that overall. We need to look at that also broken down by different age groups. And we are in the process of trying to assimilate those data to learn more about what that experience has been.
But we don't have that data right now.
No, we don't. We are in the process of sifting through it with colleagues at the state and local health department. It's really important, a really important question, and I think is going to be an important guide for kind of next steps. Catherine, I know there were more questions and I'm just blanking on. There was another part to your question that I wanted to be sure to answer, and I'm just blanking on what it was. It was the latter.
How about we come around as we go through everybody?
Sure.
Okay. Thank you, Dr. Hirsch. Nate?
Yeah, for sure. Thank you for being here tonight, Dr. Hirsch. It's always a pleasure to see you on our screen. My question is really going to dial into, kind of the developmental makeup of the immune system with kiddos. So it seems like there's a lot of social factors between, say, like a high school aged kid and an elementary aged kid. But I'm reading a lot of studies that one of the reasons potentially that elementary aged kids in that 0 to 9 range might not be as strong of a vector or might not be transmitting the illness as significantly as, say, as the older adults is based on the types of immune systems or the enzymes that are still developing within their immune systems or in their bodies. Can you give us a crash course on the validity to that number, being that you're a immunologist for kids, right? And
yeah.
And if that does play a significant role in where we're at with schools right now.
Well, yes. So first of all, it's my view that in the grand scheme of things, those differences probably, should they exist in terms of susceptibility to COVID-19, just becoming infected, the severity of illness piece is actually, a whole separate discussion, really doesn't play into transmission risk. But we can briefly talk about that. But it's my view that the questions around susceptibility to infection and efficiency of transmission are probably negligible and probably not important enough, should there be differences at all, probably not significant enough to influence policy. But there are reasons to think that it's possible that some children, especially on the younger side of the school age distribution, there are reasons to consider that they may be less susceptible to acquiring infection. And they include just how kids intermingle, but they also include immunologic considerations. One is the fact that there are other coronaviruses besides SARS-CoV-2 that are considered seasonal coronaviruses that cause the common cold. And children and immunity to these coronaviruses is not long lasting, and children are more likely to experience these other related coronavirus infections than adults are. And so if you imagine a period of let's say 1 or 2 years where you may have recently acquired another coronavirus, which may potentially have provided some level of cross immunity, that children are more likely to have that sort of cross virus protection than adults might be, just based on their exposure to other coronaviruses. That's been one kind of idea. Another biological consideration is that the receptors in the lung that are referred to as ACE, these receptors that are necessary for the virus to bind to the lung and gain cell entry into the lung, which is where most of the most severe clinical manifestations occur. Those receptors are less plentiful in youth than in older children, in younger children than in older children and in adults. So there's this idea that they may just be biologically less capable of developing infection in the first place, and certainly severe disease. The transmissibility part of it is really kind of a tough one. I think early on in the pandemic, Superintendent Madden showed some interesting data about the share of total infections that were responsible, that children were responsible for. For the first couple of months of the pandemic, children were only responsible for, 1, 2, eventually about 3% of total infections for a period of time. And that's now shot up to the most recent data nationwide. Children are now responsible for 11% of all infections. So early on, they were sort of underrepresented relative to their share of the total population. And this led to a lot of questions about, maybe children, are not as susceptible to this infection as adults are. Maybe they're not transmitting it as efficiently. But they've kind of caught up in the last few months, and things are sort of leveling out, such that these questions that we had early on about, maybe they're a lot less susceptible and maybe they don't transmit as efficiently, seem to be kind of less and less the case. And I think the other sort of consideration is there's no other respiratory virus that we've ever seen before where children are not important contributors to transmission overall. And I think that what we observed in this pandemic is that for the first couple of months of the pandemic, especially, children's interactions relative to adults, schools closed, there was a lot of sheltering in place, a lot of social measures that really protected the interactions that children had. And then gradually over the last several months, children have kind of come out to play a lot more and kind of participated in social interactions, more closely resembling sort of normal. So I think what we're seeing now is sort of a catch up, and this, some of these ideas about immunologic protection and being less efficient transmitters. While there still may be something to that, it's probably not such a significant difference as compared to older children and adults.
Go ahead, Sam.
Hi, I'm sorry, I was having a trouble unmuting myself there. Thanks for being with us again, Dr. Hirsch. So I thought you said something earlier about the absence of evidence not being the same as proof that young children here in Salt Lake County are not spreading the virus at a high rate to adults or to each other. Given the situation that we're in, where many people that I talk to that are encouraging me towards the cautious side of the approach going forward have mentioned anecdotal experiences with the health department and contact tracing, where one person, for example, said that their child was in a daycare and was exposed, and they didn't hear about it for 6 days. Which is obviously a concern. So I guess I have two questions about that problem. And the first is just, what would we be looking for to see, like, is there a way to look at the data that is available, some of which we've used in establishing our own metrics, to know when we'll be back down to a time when we can really trust what we're seeing from the schools anecdotally? Because I think that part of the fear that a lot of us have is that there's no mandate for testing, right, for the little kids. So clearly they're not showing symptoms at school, and we've seen that only I think 2 K-6 schools have had to shut down per the health department's requirements. But we don't really know. I mean, there's not a testing regime there. So I guess that's one question. And then the other question is, in your work with the HERO project, have you seen any patterns that are radically different from what we see just looking at the county dashboard that would be useful for us to know about?
Oh, these are really important questions, Sam. So first of all, I want to just clarify, children are transmitting this virus. There's no question about that. The question that I think, when you refer to an earlier comment that I made that I was talking about, is what we don't have evidence of, and again, the absence of evidence doesn't prove that it's not happening, but if it's not happening, you wouldn't have absence of its evidence. But what there does not seem to be evidence of is transmission within the school environment. Children are transmitting this virus outside of school in their life. There's no question about that. They're transmitting it amongst their peers, in the home environment. We know that. The question that we're really focused on here is, what is the incremental added risk of attending school and participating in school activities in a heavily supervised, high compliance with mitigation strategies setting? That's really the question, at least that I'm most focused on. Just to clarify that, because I think that's really important. Because again, to Nate's earlier point, the narrative or the idea that children don't transmit this virus efficiently, which was propagated for a long time, in part because children were underrepresented among cases. There was reason to wonder about that. But Sam, you also brought up the question about asymptomatic infection. And we also know that children are more likely than adults to have asymptomatic infections, and certainly more likely to have very mild infections. So, it's a little bit of like sleeper infections, and there's potential for more undetected cases among children. But really, again, what we are, especially, and you mentioned the HERO project, and what we're most focused on with the HERO project is trying to better understand how efficiently or to what extent is this virus transmitted within the school environment. We know that we have to assume, in fact, we know that young children are entering school environments now, asymptomatic and infected. The real question is, what happens as a result of that? And if our mitigation strategies are as good as we hope that they can be, then transmission will be very rare. So that's kind of the main focus. What we've learned so far with our HERO work is we've we've tested a number of classrooms after incident positives, whether it could be an adult that was detected either through just regular clinical care, they got sick, or through screening that we had done. And then we've done we've done kind of ring testing among classrooms after an exposure had occurred in a classroom. So for instance, a teacher was infected but didn't know it and taught the class for a couple of days, and then eventually became symptomatic. And we've had the opportunity to test the whole classroom. We've done this a number of times now, and we have found no evidence of secondary transmission in classroom environments when either a student or a teacher has tested positive. Again, that doesn't mean that it hasn't happened. And we've done follow-up testing serially, a week after the exposure, 2 weeks after the exposure. Doesn't mean that it hasn't happened. We haven't been able to test 100% of students in classrooms in our work, though we've, because people have to voluntarily participate, but we've been able to test the majority of classrooms in this context. And we have not found secondary transmission to have occurred. But we know that the rate of secondary transmission is a single digit number. I mean, the existing studies from outside the US, that have attempted to make estimates of the probability, what's referred to as the secondary attack rate, so the probability that transmission occurs, say, within a classroom. The convergence of studies is somewhere around 1%, 0.5%. These are data from studies outside of the United States. There's a lot of other, there's a lot of different factors that go into this: classroom size, distancing. Some of the investigations that have been conducted that have found very low in-school transmission rates haven't always been in the context of universal masking. But we don't know what that percentage is. Understanding what that percentage is critical to understanding how safe we can make our school environment. But it seems like it's a small single-digit number. So in order to accurately estimate that, I mean, if you kind of think through this mathematically, if it's 1 or 2%, you have to do lots and lots of tests before you'd expect to find a positive. So I would say in the work that we've done locally, while we've tested hundreds of students after exposures and haven't found evidence of secondary transmission, or rates that would exceed like the background rate, because people will, here and there, you test enough people, someone's going to be infected. We know we're in the middle of a huge surge in this pandemic, but we haven't found clear-cut evidence of classroom transmission. But in order to be more confident about those estimates, Sam, we need more time. We need to do more and more. We need sample sizes, not in the hundreds, but in the thousands, to feel more confident in our estimates in that regard. But so far, reassuring findings locally, nationally. Again, not that school-age kids aren't getting infected, they are. And they transmit it to their friends and their family members. But reassuring findings that we are not seeing high rates of transmission inside the building.
Thanks, I appreciate that.
Yeah.
Thanks, Dr. Hirsch. I think you mentioned when you were responding to Catherine's question about how students who are or young children, especially in all remote learning, are faring against their peers who are in person. You mentioned that you haven't finished that research and there's more to do,
Yeah.
but I heard you mention that you have a kind of an initial interpretation of that information. Could you speak to that a little bit?
Well, I don't have any interpretation of that information locally because we don't have the data curated sufficiently. But I have seen reports from other urban areas throughout the United States, a couple of districts, large districts in Florida, a large district in Texas, a large district in Philadelphia, that have had the opportunity to do this kind of comparison. I mean, in clinical research and clinical trials, as everybody knows, we'd like to, the perfect study would be, you would randomize students, one student goes to remote school and then another student is randomly assigned to in-person school, and you do that over, for two different populations, or maybe you'd have a third group that was a hybrid model, and you'd see and they'd live in the exact same community and live the same lives, and you'd see if there are any differences in the incidence of infection in those groups. We don't have obviously the ability to do that. And so instead what we try to do is take advantage of what we refer to as natural experiments. And we are conducting, that's a natural experiment that's happening in our county, which is that there are school districts that are in person and there's a school district that's not in person. There's, the reasons for those different strategies, I think we're all familiar with, but it is our job to then take advantage of the fact that this is happening and try to learn from those experiences. And the question, again, just reiterating the question that we have, that other counties have investigated throughout the country and have not found a significant difference in the rates of infections among those students attending school remotely versus their neighbors attending school. And by neighbors, I say that in quotes, neighbors meaning like a neighboring county. Now there's tons of potential biases and challenges in trying to make those comparisons, as you can only imagine, because no two students are exactly alike, and the risks of acquiring infection may not be the same in one school district compared to a peer school district. There's so many, but with these kinds of quote unquote natural experiments, which is sort of epidemiology terminology, you start to hope that as the numbers get big enough that all those kind of differences sort of start to balance out, the participation in extracurricular activities, use of masks outside of school, what's going on in your household, all the things that contribute to your access to care, all the things that contribute to your risk of COVID. And then again, what we're trying to think about is two large groups that are otherwise similar. The only difference in their lives is that one group goes to school remotely, one group goes to school in person. And, what we would also be, then you get into these questions about what is a meaningful difference. And so, the first question that we'd have is to say, are the kids that are attending school remotely significantly, better protected from acquiring this infection compared to their peers? That's a question, and that would be, we need to get to the bottom of that question. Whereas alternatively, an alternative consideration would be that there's no real difference in the incidence of infection between those two groups, and we need to get to the bottom of that. I think local, it's great to hear the experiences of other school districts, peer school districts throughout the country. But there are lots of differences, regionally in terms of the dynamics of the pandemic and, just how communities are using other mitigation strategies outside of school. So really the best data for us are going to be our local data.
Thank you.
Yeah.
Go ahead, Christy.
Dr. Hirsch, thanks so much for being here with us tonight. I appreciate it, and want to thank all of my colleagues for the great questions that they've asked so far. So first, before I ask you a question, Dr. Hirsch, I just want to go back to a slide, Larry, that you had in the very beginning, which was about what the schools look like. You had all of the school districts along the Wasatch Front listed out, and you said that there was 82 cases in Salt Lake City School District. Is that right?
85.
Yeah.
So 85. Knowing that our kids are actually not in school and we're in remote, have we been able to look back? I mean, is that just through extracurricular activities? Do you know for sure where those 85 cases are coming from? Because obviously it's not within the school.
So one of the challenges is, right, because they're not attending school. But one of the challenges has to do with the definition of cases, where there's a working definition that's called a school associated case. And a school associated case is a student, teacher, or staff member who tests positive, who has had any interaction with the school environment in person in the last 14 days. So almost by definition in Salt Lake School District, I think we learned yesterday, Superintendent Madden, that there was like half a dozen or maybe a dozen quote unquote school associated cases in Salt Lake City School District. Some very small number, but that
younger children. And that was in younger children. That
just
was
in elementary. And that makes perfect sense because almost none of them are, attending school. So, to define, to meet that definition, is basically impossible for almost all the students. The question that we need to answer is not school associated cases, but just cases in students who are attending school remotely in our school district. And I don't know that number but we're working on getting that number. The challenge there is coding exactly where you live and matching that to the school district as opposed to the county. And that's a little bit more complex of an undertaking, though that's something that we're working on. Mapping residents to school district as opposed to the county. We have good county level data, but before this pandemic, doing school district epidemiology was not something that we've really been had occasion to do.
So what I'm hearing you say, which I'm trying to put all of these pieces together, you've talked a little bit about, which I thought was fascinating when Nate asked his question about immune systems, and we talked a little bit about lungs. But what I'm trying to glean from this is, it sounds like what you're saying is that the research here in Utah is still pretty new, that we still need to look at what neighborhood to neighborhood, district to district, age group to age group, and be able to make a decision, because you can look at all the research that's done throughout the country. There's no doubt about that. And you can see that younger kids may not transmit, as much as our kids that are probably, casually gathering, outside, and that the the ecosystem within a school is definitely a little bit more tighter than it is outside of the school. And so where my question comes from is, I'm just a little uncomfortable with knowing that there's not a lot of research here in Utah, that the HERO project and what we're talking about, with our younger kids, that there's not a lot of information that we're going on that's regional to Utah. That's kind of what I'm hearing you say, is that we're sort of still in that learning phase, right? We can look at everything that's going on outside of Utah, but inside our state, we're still in our learning phase. Have I kind of captured that right?
Yeah, I would say though that, I would say that really the whole country's in a learning phase on this. I don't know that it would be a fair characterization to say that the epidemiologic knowledge for the around the Wasatch Front in terms of school epidemiology, or even our state, is way behind the rest of the country. There are a few, as I referred to, there's a few school districts that have been able to put some data streams together to say, to make these comparisons about students who are attending school remotely versus those who are attending school in person. But none of this has been, for instance, rigorously reviewed in the scientific literature. Not that I don't say that as a knock on the work that people have done. It's just, these kinds of investigations are complicated and take a lot of time, and you want to get it right because it's really easy to not get these things right in the practice of epidemiology and using data streams. So I think we're, I think that, in a lot of ways, we've learned a lot of things about the school experience in Utah, because we have we have more students, I think, as both as a percentage and in actual number, that are attending school in person than I think any other state in the United States. And we've seen kind of the good and the bad and the challenges, and we've certainly learned a lot. But again, I think what we have not learned, we just don't know, is what would this all, there's a couple of questions. What would this all have looked like this fall had every student in the state attended school remotely? Would it look exactly the same? Would it look better? Would it look worse? I don't know. And again, I do think that there is, I try to make these distinctions between what happens in the learning day inside the wall. That's one, arena. And then there's what happens in school related activities, which is a little bit more challenging. And again, the general consensus is that those school related activities are, contributing disproportionately to some of the case counts and case clusters. And we need to look really carefully at that. And that's where we need to, make hard choices and hard decisions about mitigation. But again, the sort of broader, the broader question is it safest for our kids to be in, is it safest for our kids, teachers, staff, and our larger community to be in an all remote environment? Or is it no different to be in an in-person environment? Or in fact, there are those who have reason to think that it might be for certain populations actually safer to be in an in-person environment, because it all becomes a question of what are you going to be doing otherwise. And so I don't think there's going to be a right answer for every family, for every household, for every, individual child. We have to look at these sort of in aggregate. But I think the jury's, from a data perspective, Christy, the jury's out. And I know Superintendent Madden and I, this is a really important priority to us and to our colleagues in the state and local health departments to try to learn from our experience so far.
That makes sense. I think that I appreciate you saying, giving that picture of, what Utah really does look like compared to the rest of the country in regards to who's in remote and who is not, that there are more in person that's going on. So for me, that is definitely something that we should be looking at. Just in our last meeting, I think Superintendent someone said, what's happening in Granite School District elementary schools? Yeah. And there's a lot of crossover because of open enrollment, and, we have kids that come from Salt Lake, and go into Salt Lake from Granite, so it's not just this isolated area of Salt Lake kids, coming into our schools. So I guess that just from a personal experience, I know that, small kids, in their class settings can, test positive. And so I think that when you say there's not high rates of transmission, I understand why you say that, but yet just for us to know that absolutely can happen, with those young kids.
You can look at, elementary age kids, get COVID and have been getting COVID this fall. And there's no doubt about that. Again, the question is where are they getting it and what are they doing with it? Those are our fundamental questions. And does attending school in person have any impact on if and how they get it and what they do with it? And by that, I mean transmit it. The other thing, Christy, that I do want to point out, or I want to point out for the group, and just in terms of thinking about Utah in the larger context of the United States, we have more kids attending school than just about any state in the country. We also have the least amount of kind of restrictions in place on extracurricular activities. There are very few states, especially thinking about the high school setting, there are very few states that have been participating in interscholastic competition the way we have. I think, it depends if you're a glass half empty or glass half full. We've nearly gotten through the whole of the fall sports experience. There've been a lot of cancellations. There've been a lot of clusters and a lot of quarantines. However, by and large, a lot of the teams have powered through and a lot of the kids have had, what they would probably describe as rewarding experiences. So again, it's sort of, there've been a lot of challenges with the extracurricular activities. A lot of our peer states that have had some amount of in-person learning have not been participating in extracurricular activities. And again, this is not optimal study design, but I can tell you that when you look at some other peer states, an example is North Carolina, the number of school-associated cases per capita is far lower than it is in Utah. And one of the biggest differences is the approach to extracurricular activities, which has been, basically completely restricted. So again, part of the practice of epidemiology is trying to compare groups and see what you get the outcome that you need to focus on, and which in this case is incidence of COVID-19. And then you try to say, well, what's different about these two groups? So I will say that, extracurricular activities is an area that, requires additional focus and attention. as a potential significant contributor to transmission. With that said, everything's a trade-off. I mean, there's a lot of benefits for social and emotional wellness and well-being for children to participate, children, youth, high school students to participate in extracurricular activities. So I don't want to say it's only about, counting COVID cases. There's trade-offs involved here. But I think that's a major difference when I look sort of nationwide at what we've done here in Utah in terms of having a lot, basically all the schools open, minus one district, compared to our peers, where the approach to extracurricular activities has been typically pretty different.
That makes sense. So I guess that, what I'm hearing you say then, and Superintendent, I'm sure this is what you all are thinking about, is that it's up to us to make sure that those ecosystems within the schools are as clean as possible, and that we're following all the protocols that we need to be following in order to keep everybody safe.
Thanks, Christy. So we've gone through now all the board members. Superintendent, before we do another round, do you have a question you'd like to ask, or I'd like to open that for your cabinet? Something you'd like to ask or bring up at this point?
I'll throw it out there for any of the cabinet members.
Okay.
We've been talking about it nonstop.
I'm sure you have. I didn't want to leave. I didn't want to leave you out.
Yeah,
so thank you, and thanks for for being here, cabinet members, board members. I'm sure you've got more questions. I know I do. So it's 6:30. Let's go around again, starting with Dottie. If you've got a question, go ahead, Dottie.
Okay, thank you. So what I'm hearing is that extracurriculars can be a really huge cause of spread because it gives that environment, especially for high school students. So in that case, I know that if high school students went back to school, we would be seeing our friends, which would mean that we're probably hanging out with a larger group of students, with a larger range of students, which to me means that that's a whole lot higher risk. However, for elementary students, especially those in lower grade levels who may not have those same aspects and behavior that high school students do, it would be comparatively much safer for them to go to school rather than high school students going to school. I also know that the school district does not have regulation on what high school students do after school is over, right? We have no control over that. So I could go hang out with whoever I wanted and nobody could say anything about it. But what the school district can do is that they can limit extracurricular activities. I know that the argument being made for sports is that, scholarships, right? And I think that's absolutely acceptable. But what I don't think is entirely acceptable is having, a large group of fans or other students cheering on other students in a football stadium when they're really closely packed together, where those same mandates of social distancing are not executed. So I would like to see that, and I hope that that would make a difference. Do you think it would be plausible that right now all high schools remain shuttered, but elementary schools can start to reopen?
Well, a couple of things. First of all, I just want to go back and trace through a number of the comments and questions that you introduced, Dottie. One of the challenges, so there's a few, with regards to extracurricular activities, I'm a bit, I will confess, I'm a bit more of a glass half full on the extracurricular activities. I think that a lot of, folks who are participating in athletics, by and large, have had a positive experience and have understand and have accepted that, there's a risk that you may have to miss a game or several games or, something in the state tournament, or may have to get quarantined, and that's a risk that you may take. That one of the challenges with the extracurricular activities has to do with our, maybe there's a theme here. We don't have the data, but our lack of data around transmission risk. And because of some of the uncertainty around transmission risk, for instance, in a team that's practicing outdoors, we've had to err on the side of caution and recommending quarantine, for instance, if a student tests positive and may have participated in a game or practice with their peers. The truth is we haven't seen a lot of transmission that seems to be related to the actual participation in a variety of extracurricular activities. We do see clusters among extracurricular activities, our best guess is that relates to the fact that students who participate in the same extracurricular activity may socialize afterwards in ways that don't enforce mitigation strategies. One of the problems with the extracurricular activities, though, is the need to apply pretty strict quarantine strategies frequently, and it becomes just very disruptive. So yes, there have been cases associated with extracurricular activities, but where the major challenges have actually occurred is not so much the cases, but the quarantines that ensue and that are rather disruptive. So that's just sort of one comment on extracurricular activities. My editorial comment on that is, if we can find better ways to mitigate the risk of having to get quarantined, in some cases that means just wearing masks during circumstances that maybe you wouldn't otherwise normally want to wear a mask, like practicing, but the more you wear a mask, the less vulnerable you are to having quarantine assigned. In terms of just thinking about the spectrum of ages, elementary, middle, high school, Dr. exactly as you said, I think you're a high schooler yourself. You have a lot more independence and autonomy as a high school age student than an elementary age student does. If you operate on the assumption that, in all the activities that a student might do, that if the in-school might be, the safest, but then the peripheral or related activities, whether that's casual social gatherings or school-related activities, might be riskier or less safe, then it's the elementary ages where generally elementary age students don't have school-associated extracurricular activities, and they're much more supervised in their day-to-day activities. I think that's just a fact. And so as a result, the ability to apply mitigation strategies nearly universally is much easier. And they don't pile into cars together after school and, drive to get some food the way high school students do and can, and, they have that independence. So I think it's quite reasonable to assume that, any acceleration of transmission would be greater in a group that has more autonomy, such as high school age students that are gathering more than in younger students. So I think that is certainly reasonable. And we see that in the epi curves. We see that, still elementary age students, the cases rose this fall, but much less steeply than high school age students. And we know that, and this is at the state level, and we know that the vast majority of elementary age students in our state are attending school in person.
Thank you.
Yeah.
Dr. Hirsch, so this is actually kind of a piggyback on what Dati just asked, because we're going into cold and flu season. So, what would be your recommendations, even for elementary age, or especially for elementary age? And also, how do you reassure teachers and staff about health and safety if they needed to return with the younger folks?
Well, we are entering cold and flu season, and there's going to be more respiratory viruses lurking than has been, than were in the summer and fall. Influenza, probably most importantly, RSV, another sort of seasonal virus that, we all deal with, quite a bit, and it leads to pediatric hospitalizations, and it leads to really bad cough illnesses in adults, and in some cases more severe outcomes. First and foremost, we need to have a major emphasis, at the state level, but right down to the school district level, for influenza vaccination. It's critical. It has a huge impact on acquisition of infection and severity of illness and transmissibility of infection. So, if there was ever a year to get those influenza vaccination rates, which, hover around 50% kind of nationwide, to, as close as possible to 100%, this is the year. Because while it has no effect on COVID, it strains schools, it strains the healthcare system. And as as a lot of us know, that, you know, we're in a moment now, you know, for instance, schools that are in an in-person model, you know, the message is, if you have any respiratory symptoms, you got to stay out, and that applies to teachers, staff, and students. You got to stay out, and in most cases, you got to go get tested. You know, so if we can reduce the frequency with which people get symptoms from any other virus, for example, influenza, the disruptions will be fewer. And of course, you know, in the final sort of cascade, the strain on the healthcare system will be mitigated. The other thing that's important to know is, of course, all the COVID mitigation strategies are respiratory viral mitigation strategies. So it's been interesting to look at our peers in the Southern Hemisphere, and for instance, in Australia and New Zealand. You know, the whole approach to the pandemic has been very different in those countries. So direct comparisons are challenging, but what is very interesting to note is these are countries with high mask compliance, and they're just finishing their flu season, and it was a flu season that wasn't. I mean, the incidence of influenza was like 1% of usual and normal, and that has to do with the mitigation strategies that are being used, kind of community-wide, high mask compliance, hand washing, social distancing. It's quite remarkable. So that's, you know, that's a little bit of a kind of riff on the importance of influenza vaccine, but I think from the perspective of a district, really doing everything we can to get as many people in the school community vaccinated as possible, having on-site vaccination clinics, you know, has long been shown to be a very effective way to get a large number of people vaccinated. I mean, you even get into questions around, you know, influenza vaccine is not part of the kind of school requirements, but there are districts around the country, there are independent schools and charter schools that are requiring influenza vaccine for in-person attendance this year. I mean, there's a lot of potential things to consider, but we've got to do better than we normally do with influenza vaccination. I think that the messaging around, you know, again, imagining a model where some people are attending school in person, there has to be a community commitment to staying home when you've got anything cooking. If you've got the sniffles, whether you're a student, a staff member, a teacher, you've got to stay home. And, you know, we've worked with pediatricians throughout the state and actually with schools as well to try to develop algorithms for how to approach, you know, who should get tested and when, and what are the kind of, you know, what are the clinical symptoms that should prompt kind of immediate testing versus maybe I can wait 12 or 24 hours to determine whether or not I need to get tested, to determine, you know, whether or not I can come back to school. So we have to create a culture that's very different than the previous culture around, you know, going to work or going to school with mild symptoms. That's just got to be really ingrained in the community. That introduces all kinds of challenges because of childcare and missed work days and subsidy. I mean, I'm not implying that this is not without its consequences, but that has to be the culture to even consider an in-person learning kind of approach. That's just got to be, you know, a lot of schools sort of nationwide that are, you know, that are doing in-person learning have really committed to daily symptom checking. And that can be done in a variety of ways. Sometimes people are getting temperature checks at the door. There's been a real growth in use of mobile technology like apps that, you know, ask you, you know, a series of questions and say you got to get a temperature taken. You know, there's mixed opinions on these. You know, a lot of people say, well, you know, people are just gonna deny symptoms and just check the boxes really quick. And I don't know if any, you know, I'm sure some of you have, if you have children, have used these for one activity or another. But the idea is that it sort of nudges you a little bit to kind of, you know, to just think twice about, you know, your own symptoms or your child's symptoms. And there's probably, you know, these don't cost a lot, they don't take a lot of time. And if they make a little bit of difference, then they're probably worth it. So that's another part of kind of changing the culture kind of around attending school. And I think the other thing too is that again, that I hear sort of anecdotally is that schools that have developed some experience with remote learning, kind of going back to the first point around kind of staying home when you've got anything, the idea, last year, if you had to stay home from school, whether it was as a staff member, a teacher, but especially as a student, you missed the school day. And, in some cases that was really challenging. You got behind, et cetera, especially for middle school and high school students. With all the experience that people have gained with remote learning, the idea can be that, you're not going to miss school the way you used to miss school. You can actually attend school remotely and get better, get your test. Hopefully that test is negative, et cetera. So I think all of that is kind of broadly what I think of as kind of changing the culture around how we participate in the school community. Again, easier said than done, but messaging around this is really critical to ensure culture really of safety. And this extends to the other workplaces as well. I mean, this is just the world that we live in, now that we're forced to. In terms of other ways that we can, hopefully reassure parents, children, staff members, and teachers that attending school is safe enough to justify it. Just kind of back to earlier parts of our conversation, we just need more data. I mean, if to really provide an evidence-based level of reassurance, we need more data. We're working on it. We're doing the best we can to accumulate data as we go. I'm optimistic that we can, have more insight from what we've been doing here in Utah so far, soon. I don't know what those I don't know what it's going to show, but I'm eager to learn.
Go ahead, Mike.
Thank you, Dr. Hirsch. You have answered my questions. I'm happy. Thank you.
Okay.
Dr. Hirsch, thank you for that information and for your reliance on data. Larry, would you put up the chart again from the Salt Lake County? I just wanted to ask you some questions. You talk about the natural experiment that we have and one group of students going to school remotely versus one group going in person. Yeah. And we talked a little bit about the 85 cases we have in the district. I mean, in some ways, isn't this the example of that? I mean, I guess what I'm asking you is, we don't have all the data yet, but isn't the data that we have right here where we're going to school remotely and everyone else is going to school in person? And I looked up a couple numbers while we were sitting here just really quickly. So Murray has 6,500 students. We, of course, have 2,100 right now. They have 6,500. They have more cases than we have. Canyons does have, about, they have, actually I didn't look up Canyons. I looked up Alpine, but so I'd have to look up.
Canyons is about 35,000, Catherine.
So 35,000. So they have, 1.5 times about, and Granite has three times. They have 67,000, so a little bit over 3 times what we have. But you're going to see that they have a lot more proportionally. So we don't have all the data, and it's not clear. And I think that those 85 cases, we know what some of them are. We know that one of them is a cafeteria worker that we heard about a few days ago, and we know that one of them is a custodian that we heard about a couple of days ago that unfortunately got COVID, probably from family members or some of the things that you said. But doesn't this sort of tell part of the story about, you said, the natural experiment? Isn't this some data that we're looking for right in front of us?
So Catherine, I have to say, I don't know, I don't know the data stream for what we're looking at. If these are the right data, then I think your point is that, there
we go.
I don't know the quality of these data that we're looking at. I don't know. The problem with this is actually pretty difficult. The conceptually answering the question really isn't all that difficult. We want to say, of all the kids that are attending school remotely in our district, what's the incidence of COVID-19 compared to all their peers who are attending school in person across other districts? That, that's straightforward. The challenge here is, I don't know if we're mapping the cases. I don't know, I guess maybe you could expound on this, but this is the Salt Lake line is 85. The issues have been whether or not we're capturing all of the cases among students who live in the district, in instance, in a chart like this, or those that are linked to school. So it's really just a quality or ensuring that we're measuring what we want to measure. But you're right on that this is the way in which we want to look at it. And then we need to denominate all of these numerators. Because, we need to look at, we need to have the right denominator, meaning how many eligible students are there. And you're getting at it by saying, oh, Murray is smaller. So you're thinking like an epidemiologist, right? I mean, if Murray is actually smaller than Salt Lake, but the case number is actually equal, then you'd say, yeah, the incidence of infection is higher. But I'm just not, the way I approach this kind of thing is with, this is so important to get right.
Absolutely.
I haven't created these data myself.
I think you're right. We don't have enough information and we need to keep studying, just like you're saying. But this is the information we have. Some of the other things that we know, we've all heard the news, much news this week, but some of the news we heard this week is the news about the mom code, and that we may not be getting the right numbers from some of these other districts that want to stay in person, right?
Sure.
So some of the cases from these other districts, we've heard about other schools that may not be getting all the cases in their districts, right?
Absolutely.
So, they may be missing cases in those other districts.
So test-seeking behavior is kind of what you're getting at. So this is the I love that you're bringing up all these things, because this is the both fun and hard part of doing epidemiology. You have to think about.
I guess so. This is the information that I'm looking at. As I look week to week, and so this is what I have, and I really appreciate your bringing information to us. So the last thing that I'll ask you before I pass it on to Nate is, one thing that you mentioned is that we could start the HERO program at different times in the school year, if that's right. Mm-hmm. And so would that indeed be possible? If we could start immediately, or could start in December? You said maybe we could start in March, you said. So is that you see that as a possibility?
So the HERO project, which focuses on school-based testing, for the moment will be continuing through December. When the new calendar year emerges, we'll see. The work that we've done so far has, exclusively focused on schools that are in person, but we're very interested in using our resources to understand, how this pandemic affects all school-age children. So we're very interested in thinking about strategies to understand how testing can help guide us through our understanding of the pandemic in the Salt Lake School District, where students, for instance, are not attending school in person. We could also think about strategies to use our testing resources should, for instance, a school make a plan to open its doors, but to have an opportunity to do testing kind of along the way, kind of a week to week kind of thing. And these are all potential strategies within the confines of our capacity and resources that we could consider. Absolutely. I think that, as we've begun over the last 4 to 6 weeks now working on school-based testing, there's just, at least for me, there's just growing recognition that, if I had all the resources in the world, one of the first things I would do would be, really scale up testing in schools, because testing is one really valuable strategy to allow for the safe congregation of students in a school environment. We know from experiences that we've seen kind of nationwide that testing alone doesn't stop transmission, but it's a very useful tool to kind of identify chains of transmission, assign quarantine appropriately, and also just kind of be a barometer of where things are. Because, as you're alluding to, Catherine, test-seeking behavior, not everybody who should get tested gets tested. And those behaviors, for lack of a better word, may differ depending on what your incentives are. And we know that, there are folks who feel disincentivized to get tested because of what it means for them or for their school. Absolutely. I do, if we go back to the chart, there's other concerns that I have though about, which makes this really challenging is, the influx and efflux of students across school districts. So you may reside in Salt Lake City, but attend school district, but attend school in another school district. And so where do you count? And if you get infected, where do you count that case? And so, frankly, the best design to better understand this is not so much based at the school district level, but just based at the individual student level. Do you attend school in person or not? I don't care what school district you're in, just do you attend school? Because attending school in one district versus another is more or less the same thing. Mm-hmm. And so again, these are the, the challenge. I am very, the chart that's up there, I don't know the data stream, so I'm hesitant to draw any conclusions from it. But it's those kind of charts that would then be denominated and converted into rates that we need.
Right, exactly. And I just want to go back to and just congratulate Dottie, because I think she's always been on track that what we need is the program that you have testing, and the faster we can get those results, we could be, really getting our kids back to classes. And if we could do, I understand the legislature is going to do rapid testing. Yeah. And I wish that we could get our society to think of our students as important as, I think the legislators are very important. They're doing important work. And I wish you could get our society to think of our kids and our teachers as important as we think of our legislators, and I like the way Dottie thinks. And, we need to think of our kids and our teachers as important as we think of our legislators. And people like doctors often get rapid tests. We need to think of them as important as that. And that they need rapid tests too, so they can be in the classroom every day. Thank you, Dr. Hirsch. Appreciate it.
Yeah, I agree 100%.
All right. So my last question is, basically the same question I asked you last week, Dr. Hirsch, and it probably dovetails on a lot of other, kind of points and questions, and certainly a few things that you've alluded to here. But as I've been trying to put this question, together in my head, I've just kind of named it the puzzle piece question, right? And this more or less comes from my systems theory, thinking and training as a social worker. And I know that we're just one component, right, of a larger system of a community and a state and a city. But it looks like obviously testing and the way that you've described it is also just another component of a larger system of strategies and components as well. And knowing that, what we're up against here with this virus in, in the realm of, state and county and city regulations, when you think about social perception and then subsequent social behaviors, some of which we've talked about tonight, mass compliance, testing capacities, transmission rates, and then we also add up some of these other factors like ICU beds coming at capacity all across the state, contact tracing here in the Salt Lake County Health Department potentially being at risk of not being as effective just relative to their own capacity and able to contact everybody that is needing to be contacted. Do all of these strategies and pieces add up to a school district being able to open up school at any capacity? Do all of those factors socially, politically, medically, do all of those add up for us as 7 decision makers on this school board to be able to do this effectively and safely in a way that doesn't impact the already sensitive, kind of environment that we exist in relative to our health department and our medical industry, and then of course our students?
You framed it really well. And this is an extremely complex ecosystem with lots of interrelated parts, and no one, component necessarily is all these different components interrelate and are influential in different ways. I don't know. I don't know the answer to that question. I think that, ultimately these decisions there are different approaches to the decision. In some districts, it's been kind of an all or nothing kind of thing. We've got to have, we're going to do it, and we're going to do it all. Other districts, regionally, nationally, have taken a much more incremental approach. A lot of districts, are approaching school exactly the way Salt Lake School District is. And there's just a lot of considerations that go into it, ranging from what the current ICU capacity is down to the community will, to the preferences of the decision makers, to the general preferences of the teachers and staff. So there's just so many considerations. I don't know that there's necessarily, a right way to do it or a wrong way to do it. What I think is as important as just about anything else is using evidence to guide decision making and being willing to read the tea leaves, whatever you decide to do, and adjust course as you go. I mean, I know the school district has a great leader in Superintendent Madden, who's, been, as I've had the opportunity to have a number of conversations with him, he's, wants to be an epidemiologist and says that's the profession that he would choose if he could, pick another one. And I think that we're really fortunate in this district to have a leader who is helping to guide the decision making using a very cautious but data-driven approach. I think, again, the wrong approach or the dangerous situation to be in would be to have leaders and leadership that was, kind of just dead set on one outcome, no matter what the tea leaves and the evidence shows kind of along the way. So being willing to react and respond to this complex, dynamic pandemic is, probably more important than kind of what the specific decision is. I think that we've, collectively discussed that, there is a difference in risk and risk of disruption and complications. There's clearly differences when you talk about the oldest school-age children and the youngest school-age children. The oldest school-age children, although all school-age children tend to have, really favorable clinical outcomes with this infection. The oldest school-age children, adolescents, are more likely to have severe outcomes. Not that it's common, but they're more likely to have severe outcomes with COVID-19 than the youngest school-age children. Of course, regardless of the school environment, there's adults in the mix, staff and teachers, who are obviously more vulnerable to severe outcomes from this infection than youth are. But again, what it really gets down to is how safe is the school environment? And what we are seeing, and the emerging theme, is that it's one congregate, it's one of the safest congregate settings that we have. No congregate setting is, has zero risk of transmission. And if, clearly, if our risk tolerance for COVID transmission is zero, then, we can't open any schools. We have to be, we have to think about, is there some amount of risk that can be tolerated, not just for those involved with the school community, but for the larger ecosystem, Nate, that you allude to. And again, we didn't know when this kind of all started, were we going to see this virus, whizzing its way around schools? I mean, people kind of forget that, it wasn't really that long ago that, our state made actually one of the earlier states to make the requirement that all participants in school communities are required to wear masks at all times. That's kind of become there's really no school that I'm aware of in the US where masks aren't required, but that was a commitment that our state made kind of early on. And it's, at least in my view, the single most important mitigation strategy.
Thank you.
So, Dr. Hirsch, my question for you, my second question for you. So we've obviously had a lot of discussion about different groups of kids, and we've elected to bring back our special education students and our multilingual learners in small groups. And then, so there are all those federally defined categories of students from an educational perspective. And then, of course, there are, groups of students that are based on the system we have, where we have elementary school that ends in 6th grade and high school that starts in 9th grade or 10th grade, depending on what part of the country you're in. So I guess clearly there's circumstantial evidence that younger kids may present a lesser risk. I'm interested in where you would draw that line, because the data that we were looking at in the PowerPoint, I think was 0 to 9. If you were gonna make a category based on age, or categories plural, what would they be? And are there other categories that we should be thinking about in our student population that maybe aren't educational categories, or categories that we would be aware of from that perspective that you would encourage us to think of?
Yeah, I mean, so posing a hypothetical, Sam, if we were to say we have to allow we are going to allow one age group to participate in in-person learning. I mean, I think that for a variety of reasons, the age group that's less than 10 or less than 12, kind of depending on the epidemiologic study that you look at, that's the group of students where we know there are a couple of facts. The severity of illness is least in that age group, defined as either less than 10 or less than 12, and that happens to sort of coincide with elementary school. I mean, you got to think about sort of the operational logistics. And then again, I think it was Dotti's point earlier in the conversation, the ability to kind of supervise and kind of regulate school-related activities and activities that would benefit from masking, and to sort of ensure mask compliance. So it seems to me that if you were going to pick an age group to participate in in-person learning, and that desire was to have an age group participate in in-person learning and mitigate risk, have the least impact or no impact on community transmission, or in cases in that population, that would be the group. I mean, I think for all of those reasons. The issue around transmit, and I'm not even talking about the questions that remain about susceptibility to infection and contagiousness, because those are important questions, but I don't know that we, frankly, I don't believe that any differences in susceptibility to acquiring the infection in the first place and transmissibility of the infection in the second place, that any differences that may exist are enough to kind of be important in guiding policy. Children, young children, older children, they get it and they spread it.
So it sounds like
strategies aren't used. The issue to me focuses on really the two things: susceptibility to severe infection. That is very clear that younger children, and children, I mean, up to age 18, quite frankly, is often defined, experience severe outcomes far less frequently than adults. And the younger age group, less than 10, less than 12, again, depending on the epidemiologic cutoff that's used in the study, well, in the context of school, you'd be really talking about the 5 to 10 or 5 to 11 age group. Less than 1 year old is a higher risk group, but ages 1 to 10, 1 to 12 probably have the most favorable clinical outcomes. The most likely to be asymptomatic, and then when symptomatic, the least likely to be hospitalized, the least likely to require intensive care, et cetera. So I think the convergence of those factors, that's, and it's for those reasons that in school districts or schools that have had, a heterogeneous approach to reopening, that generally elementary ages have been prioritized over older students. That's what we've seen both in the United States and abroad as well.
And so to what extent would you say that differential is kind of, I don't want to say canceled out, maybe is the closest thing to what I'm trying to say, by an environment where kids come in sick all the time and they can't be sent home, it's impossible for the school to require testing, and it's impossible to disclose, obviously, who's sick with what illness.
Well, I would encourage folks to, talk to peer schools and peer elementary schools in neighboring districts around, kind of what you're getting at, Sam, which is the issue of, there was a lot of concern early on to say that, oh, we're going to, half the school is going to be out sick, all the time. Anecdotally, I don't have these data because it's not really my business, but anecdotally, what I've heard is even though the threshold for staying home has been lower in a lot of places, and we're gonna, you get sick during the school day, there's not going to be any question about, oh, go get some Tylenol from the school nurse and then maybe you'll go back to class, you're going home. Anecdotally, what I've heard is that school absences and I don't know what you'd call it, like instances where you have to send kids home, have not been any different than norm. And in fact, in some school environments, what I've heard, again, anecdotally, is it's been actually less. Some people attribute this to masking, that people are using masks more. I mean, we've got a raging pandemic of one virus, but some of that's offset. Some of the other viral transmissions are offset by all the mitigation strategies. So I encourage folks to get some feedback from peer schools around that issue of sort of that the disruption that's introduced. What are schools in Granite and Jordan, peer districts, what are they experiencing? Charter schools in Salt Lake City, what are they experiencing in terms of the disruption around, people not being able to come home, the childcare issues, the substitution kind of issues because teachers or staff get sick, et cetera. It all what I'm hearing is that maybe it all cancels itself out. But those are really important operational questions because the need for substitutes, maybe, in this new culture and new environment that we're talking about, maybe the need for subs would be greater. The challenges for caregivers and parents to find childcare, more often when their child has to stay home unexpectedly because they wake up sick. These are important operational considerations.
And they might well be very different for us than they would be for suburban districts.
Absolutely.
Thanks.
Thanks, Sam. I have a list of questions here that I've compiled, Dr. Hirsch, Superintendent Madden. I'll ask one more, but I'm wondering if I can just submit these questions perhaps to you, Superintendent Madden. Maybe you can share them with Dr. Hirsch and I can get answers to them. A lot of them have been covered by my fellow board members, so thank you for the good questions you've asked. I'm afraid this may not entirely be in your wheelhouse, Dr. Hirsch, but I'm hoping you can help me with this. I'm hearing from more and more families that are really concerned for their children's mental well-being, telling me things about depression, anxiety, lack of interest, social isolation, headaches. I've also read statistics that say a student who doesn't graduate from high school has a 9-year less life expectancy than than somebody who does graduate. I'm kind of trying to figure out, how you might recommend balancing all of those issues against the risk of the virus itself, knowing that we want to keep kids safe in every area of their life, but our focus really is about educating them. So I'm maybe hoping you can speak to some of what the compromises we may need to make in order to balance all of those issues as well.
Yeah, well, it's such an important set of considerations and questions. And obviously there are trade-offs involved. And obviously for most, I do want to start by saying, there's no question that for some, and I'm sure people can attest to this, for some students, the remote learning environment is better. I have heard lots and lots and lots of stories about, some students thriving in the school environment, like they've never thrived before for any number of social and emotional reasons. Sleep, getting more sleep. I've heard that anecdotally that, for instance, some of the schools that are in hybrid kind of models, that some of the students saying, I kind of like this because a couple of days of the week I get to, I'm not in as much of a rush to get to school at the early start time. So there's clearly a group of students, and and not a small group, for whom, you know, remote school is a good fit, and, you know, independent of the pandemic. And I think that, you know, it's just important to acknowledge that, that this, you know, one size does not fit all. But with that said, I think it's probably also fair to say for most students and families and staff and teachers, that, you know, they want to be in person for most, let's say. And there's clearly lots of benefits to the in-person experience in terms of optimizing learning, socializing, which for many, you know, and for educators, you know, I mean, most educators in the district didn't go into the profession to teach remotely. I mean, I think that's, you know, I think obvious, but trying to account for the trade-offs that are involved, and I mean, there's just no question that there are substantial negative consequences for students and it's not just not attending school, it's just, it's more than that. We're living through some of the darkest times in some ways in a lot of our lives. I mean, it's not just that you're not going to school, it's that there's fear and anxiety everywhere, that there's intense polarization politically in our communities. There's intense polarization around just school policy, intense polarization around the issue of masking. So there's just so many things that youth are faced with. There's, high rates of unemployment, there's job uncertainty, food insecurity. So many more people. And so it's hard to almost disentangle, remote, because, participating in school remotely in normal times might be a lot, less detrimental than participating in school remotely in the times we're living in right now, because there's, we're doing school remotely because of the times we're in. So, I mean, those, my, on the one hand, my immediate reaction is, well, let's measure it. Let's see, you hear anecdotes. Oh, there, we're seeing people hospitalized at primary children's with, suicidal ideation, et cetera, et cetera. But, that's always the case. Mental health challenges are ubiquitous. They've been on the rise, especially in adolescence, for some time, actually. To what extent the pandemic has exacerbated those challenges? I mean, I think it's unquestionable that it's exacerbated those challenges. And again, it's for a larger public health benefit, mitigating transmission of this virus. But there, inherently in the end, in terms of making policy, I mean, I think we do have to at least try to explicitly think about the weighting of the trade-offs that are involved, and the consideration that, the consideration of the possibility that in-person learning might increase transmission slightly or more than slightly. But has its benefits. And I'm not here to, adjudicate those trade-offs for anyone. I mean, those are really hard decisions. I don't envy anyone on the board having to make such challenging decisions that affect so many lives. Those are, extremely, extremely hard decisions. And I'm sure just based on the questions I'm getting, obviously, all of you are acutely aware of the trade-offs that are involved with these decisions. I think that, obviously the current policy reflects an assumption and a view that school could be a risky place for viral transmission. And I want more data to know if that assumption is right on the money, or maybe we've tilted, especially for perhaps the younger kids, tilted towards assuming that attending school in person was riskier than maybe it turns out to be. I don't know, but we're trying hard to learn more. But clearly, I mean, I guess I think it sort of clearly, in summary, if the risk of attending school in person is, really not elevated above remote, or if it's minimally elevated, I think, there needs to be consideration of the other negative impacts that kind of staying away from your peers in person has, and balancing those trade-offs is a really hard decision.
Thank you. Christy?
Okay, Dr. Hirsch. So I'm going to probably stick my neck out a little bit and go off of what Catherine was saying and say that, you know, students are our future. So I actually would prioritize them over the legislature, you know, for that rapid test. You know, I think that that wouldn't even be a question for me. So I love how you've been talking about schools as ecosystems, you know, because I think that that's the way that we need to look at them. So we've talked a lot about and had great conversation, you know, of what it looks like with younger kids. But I want to get your advice or maybe your insights on a very specific category of kids that, you know, Sam alluded to earlier. How would you categorize? So right now we have schools that just recently in the past couple of years where we have gathered our special needs kids in very specific pods, you know, across the district. You know, we have some hub schools, you know, that vary from learning disabilities, you know, to severely medical. And then also we have an inclusion program in several of our schools, which means, you know, that our kids are being put in classes with the gen ed kids. So when you think about that and the possibility, you know, of us getting a recommendation from the superintendent and staff to look at bringing back our pre-K through 3 kids into a in-person setting, what would be your advice in regards to how we handle our SPED kids who have been in the schools pretty isolated in small groups, you know, since June?
Well, first of all, I mean, I think it would be really important to learn from the experience of the kids, the small number of kids who have been attending school. I don't have any insight into, you know, case counts in those groups, any clusters of cases. I think I would have heard or would be aware of significant challenges with cases should they have occurred. I haven't, but, you know, that may be something that Superintendent Madden can, you know, can inform us about either, you know, now or in the future, because obviously that's a much more, you know, smaller number of students and perhaps a more supervised kind of type of setting. But again, I think, you know, there's going to be lessons learned about operational, you know, how to operate school, how to, you know, allow people to arrive and get picked up safely, how to do lunch, how to move between, you know, classrooms. I mean, I think some of the arguments that have been made for, you know, again, operating the assumption of opening schools for some in-person learning, some of the arguments that have been made to do it, you know, not just open everything all at once, have been that, hey, it's like the operational challenges in this day and age are very different and new and challenging. So let's bite off a small chunk, you know, just a smaller number of kids that are going to be coming and getting dropped off and picked up and going to the cafeteria or eating in the classroom, just working through, you know, kind of just the logistics of how to operate a school in these times, incorporating these mitigation strategies. You know, what I've heard, you know, over and over again is from staff and teachers is the job is a lot harder than it ever was before. This is a really hard job in normal times, and the job is a lot harder, whether that's because you're worried about ensuring that students are keeping their distance, which isn't natural for any of us, whether it's, you know, new responsibilities for cleaning and disinfecting, whether it's, you know, just the general anxiety that people have about the virus, you know, just to begin with, and especially the first few weeks of in-person learning have been really anxiety provoking from what we've heard for a, you know, a large swath of the school community. So I would say, first of all, we'd want to learn from those who've been kind of doing it a little bit in our own district, and, you know, again, in peer districts, what works well. Oh, and I should say the other huge challenge has been for educators, right, has been the two groups, the in-person group simultaneously with the remote group is just, you know, mentally taxing in a way that's just above and beyond kind of, you know, the way we used to do things. So it's just a lot harder, you know, than it ever was. So I think we need to learn from, but at the same time, what you do here is that you know, like all things, students adjust, students adapt, teachers, staff adjust and adapt, and you get the hang of things as time, you know, as time goes on. I don't know if you're asking how to imagine having the small subgroup of students with who may have special education needs, or who may be at risk of, you know, among older students who may have been at risk of not graduating, who are being offered the opportunity for some in-person learning. I don't know if you're asking about how they might intermingle or cross paths, or how the introduction of two populations simultaneously might create more logistical challenges. I apologize, Christy, if I'm not quite
No,
following.
that's okay. I think that, again, you know, might not be in your wheelhouse to talk about, or, you know, the experiences or what you've heard about. But I'm just thinking about, you know, as we introduce our gen ed kids into the schools, you know, and that our special ed kids, you know, who are actually, you know, a more fragile category of kids, you know, what your advice would be. And it sounds to me like you're saying is continue to, you know, to look at the mitigation risks, you know, keep them as low as possible. And there's a lot of mingling, especially when you think about, you know, our inclusion programs, you know, where our SPED kids are mingling in with our gen ed kids. And right now, a lot of them are the ones that have been at the school in small group instruction. And so I think I just wondered if that was something that you and your colleagues have talked about or seen across the state, you know, that you would be able to advise us as we move forward into looking at this recommendation through the superintendent and staff. And maybe, you know, Larry, it's something that you'll even be sharing with us, you know, on the 3rd of November. So I just wondered if you had some insights to that.
My only comment, you know, thank you for clarifying. You know, I think most schools, at least in our state, you know, have been operating quite differently, kind of, you know, everyone's there, gen ed, special ed. So maybe haven't kind of faced this challenge, but I think what we've heard kind of over and over again is the first day, the beginnings of this is challenging, you know, and some of the students have been there already, you know, having more people, should more people come into the building, could be disruptive, could be a challenge, like initially to say, hey, you know, I've got used to a certain kind of scene in my school space, and now there's a lot more people, there's a lot more chaos, and that could provoke anxiety. I mean, so those are, I think, that's not something I thought about, Christy, but I think that's a really important, you know, set of considerations these times. But I think, yeah, those, you know, the reintroduction is, you know, in some ways, you know, you hear stories that it's, you know, it's hallelujah, but I think for a lot of people, staff, teachers, students, it can be very anxiety provoking. But there's adaptation is kind of what we hear over time. But it's the new normal is a lot harder. I mean, I don't think there's any way to sugarcoat that. I mean, that's what I hear over and over and over and over again is it's a lot harder especially for staff and teachers.
Thank you, Dr. Hirsch, and thank you, board members, for your questions. This has been really helpful. I think it's been a really positive conversation, lots of good questions asked. I'm sure if you have more questions, board members, I am going to suggest that you submit them to Superintendent Madden, who can work with Dr. Hirsch and get us back answers if you've got other questions. You've been generous with your time, Dr. Hirsch, and we've spent 2 hours on this, and I'm sure we could probably continue discussing it. It's interesting. I think these are difficult times, as you've said, and the new normal is certainly very stressful and very hard. But I applaud all of you who are here and spending your time thinking about this and learning about this, and knowing we've got a board meeting just a week from today, and we had a week ago from today. So I appreciate all the extra time you board members are spending on this right now. I'm going to go ahead and call the meeting adjourned. And thank you all for being here. Superintendent Madden, do you have something you'd like to say as we end?
Just thank you to Dr. Hirsch, and then thank you all for your questions. And it's greatly appreciated. And I think the tone of we're going to keep learning. We learned some things today, and in a week we're going to learn more, and in 2 weeks we're going to know more, and in a month we're going to know more. And we just have to be, I think we have to be willing to, you know, roll with that. I mean, we'll get smarter as we go, and that'll inform our decisions. So thank you all.
Thank you, everyone. Have a good night.
Okay. All right. Thanks, everybody.
Thank you, Dr. Hirsch.
Oh, my pleasure.